I am Olaoluwa Ezekiel Dada. I am a research fellow of AFAN and also a member of the operation department of AFAN. I'm a second-year medical student from the University of Ibadan, and I'm glad to be present in this second Neuro Oncology course presentation. So it's really great having everyone here. Credo, can you unmute yourself and present yourself? Tunde Olabatoke, present yourself.
All right, thank you. Olabatoke Tunde, a medical student in the University of Lagos in Nigeria. I'm really happy to be here. Thank you.
Thank you, Tunde. Welcome. Dr. Kabulo, please unmute yourself and present yourself.
Good morning, good evening here, everyone. My name is Kabulo, neurosurgeon in Lubumbashi. Thank you.
Yeah, thank you, Dr. Kabulo. We are glad to have you here again. Thank you so much. Daniel Safari, Dr. Daniel Safari, please unmute and present yourself.
Good evening, everyone. I'm Dr. Daniel Safari, a research fellow of AFAN, and I'm equally an academic assistant at Official University of Bukavu, School of Medicine. I'm glad to be with you this evening.
Thank you, Dr. Daniel. We are happy to have you here today. Darwin, can you please unmute and present yourself?
Good evening, everyone. My name is Darwin Chimba. I'm a medical student from Copperbelt University School of Medicine in Zambia, and I'm the Director of Operations for the Association of Future African Neurosurgeons, and I'm very glad to be here. Thank you very much.
Yeah, thank you so much, Darwin. Glad to have you here today. Utomi, please unmute and present yourself.
Hello, everyone. My name is Alice Mutoni, medical student at University of Rwanda, in Rwanda, of course. Glad to be here tonight. Thank you.
Dr. Ulrich, please unmute and present yourself.
Thank you very much, everyone. Hello, so I'm Ulrich Sidney, the founder of the Association of Future African Neurosurgeons. Glad to have you here today and looking forward to the presentation.
Yeah, thank you so much, Dr. Ulrich. We are happy to have you here today again. Berjo, please unmute yourself, present yourself, and go ahead with the presentation. Thank you.
Thank you very much, Ezekiel. Greetings, everyone. I am Takoutsing Berjo, student, and I'm the presenter of today's course, Neuro Oncology Course, the second case. Okay, thank you very much once more, everyone. So today we are going to, I'm going to give a presentation for the Neuro Oncology Case 2. So today's case is we're talking about glioblastomas. So as for the plan, I'll first of all give a case presentation, and then I'll give a little literature on the glioblastoma. So as objective, that is, before finishing this session, each panelist should be able to approach a patient who have the same clinical presentation which I'm about to present, understand the epidemiologic condition and management and prognosis of glioblastomas, know the principles of glioblastomas, and know the genomics of glioblastomas. So now I'm going to start with the first part of the presentation, which is a case presentation. So I'm presenting a 55-year-old male who presented with headaches of 2 weeks, weakness of his left arm of 2 days, nausea, and poor memory. I'm presenting the headache generalized. The nausea and vomiting were associated with abrupt changes in position. Was previously healthy prior to the onset of the symptoms. On physical examination, generally, the headaches were producible by bending over or coughing. On examination of the nervous system, there was left homonymous hemianopsia, left nasolabial flattening on examination of the cranial nerves. There was 4+ on 5 weakness of extensors in the left upper extremities and mild spasticity in the left upper extremity. The rest of the examination of the other systems was apparently unremarkable. I just presented a 55-year-old otherwise healthy female who presented with reproducible subacute headaches, acute left arm weakness associated with nausea, vomit, poor memory. On physical examination, anopsia and left pyramidal syndrome on the upper part of the body. So this is just a detail of the summary. So since this is an interactive session, I would like one or two panelists to help me propose a diagnosis based on the case that I just presented.
Okay, possible differential diagnosis could include a neoplasm, which could either be primary or secondary, like a primary brain neoplasm or secondary metastasis. There could be a possibility of an infectious process going on that could be causing a space occupying lesion, so probably an abscess or a cyst or something. It could also be vascular.
Oh, that's awesome. Thank you very much. Any other person can give a try? Any other person? So thank you very much for the diagnosis. So now, for the diagnosis of this patient, I'll make a diagnosis of a space occupying lesion. So this diagnosis is made based on the fact that the patient signs and symptoms, notably headaches, nausea, and vomiting, with focal deficits, which were the left homopsia and subtle left nasolabial flattening. But from what you just gave, so I'll just go directly to the differential diagnosis, because what you gave are the possible differential diagnosis for this presentation. So, as you rightly elaborated, which I think is a very good approach. Like you separated them into neoplastic, vascular, infectious, and I'll add others. So for neoplastic, as you mentioned, it could be a primary brain tumor, metastasis, especially the patient has a history of cancer. It can also be a CNS lymphoma. It can be a stroke. It can be arteriovenous malformation, a cavernous malformation, or brain abscess or encephalitis, depending on the associated symptom. But for this case, we saw clearly that there were no features that would make another possible different diagnosis in this case would be radiation necrosis. Like, let's say in case a patient had a tumor before, maybe had a radiotherapy done, so this will make you think maybe it's a radiation necrosis causing those signs and symptoms. So with the diagnosis and different diagnosis, I don't know, can someone just propose me the next best step? Because we have a diagnosis of space occupying lesion, we have a variety of differential diagnosis for this patient. So what is the best next step for you to have, to have a working diagnosis for this patient?
Yeah, we need to do some sort of imaging, I guess. So maybe a CT scan or a brain MRI. Since we're thinking of a space occupying lesion.
Okay. Thank you very much. Exactly, the best next step for this patient is neuroimaging. We had the following CT scan done. So here you have axial CT with a brain window for the patient I just presented. So I don't know, can anyone just give me the axis on the CT scan?
I think I can go on this one here. So first of all, I think there is an issue. The image has been distorted. It's been dragged, elongated more on the width than it should have been. So it's a good habit to keep it in the right proportion. Okay. So what we have here is CT scan without contrast. Like you said, it's an axial cut, and we can appreciate at the level of the right parenchyma, we can appreciate some hypodensities, which are, yes, thank you for pointing them out. And we can see that these hypodensities are causing a mass effect, because we can see the ventricle horns, the frontal horns are shifted. So we see the mass effect there. Other than that, I don't see anything particularly alarming, although there's what might be, it's just the quality, what might be as well some kind of, I would venture myself to say maybe some edema, but the quality is not the best for me to say that. Yeah.
Thank you, Doctor. So, like for this, actually, as you said, you have multifocal hypodensities at the level of the right frontal and parietal lobes with mass effect and midline shift. As you rightly said, that the edema actually with this CT scan is like you cannot actually appreciate it. So for this patient, was also requested the MRI, which you have the slide shown here. So here I'll just go directly and just interpret what is there. So as you can see, so here is a T1 MRIs with contrast, and here you can have the ring enhancement, but here it's particular in that you can see that the enhancement is kind of irregular. It's irregular on here. See at the level of the frontal and parietal lobes, and here you can the corpus callosum here is also involved.
Okay, here you mentioned that the hypodensity lesion is on the frontal and parietal lobes. Don't you think that there's also part of this tumor in the temporal lobe?
Pardon, doctor, I'm not getting you, please.
I'm saying, don't you think that part of this tumor is also in the temporal lobe? Because you only mentioned parietal lobe and
yes, I do.
Because check on your right side, on the left side of that image. Can you point? Can you see the Sylvian fissure?
Yes, I'm seeing this.
Can you point the Sylvian fissure, please, on the left side? Yes.
This is
it means what is on the right or back of the Sylvian fissure? That's the temporal lobe, and that's the same image on the other side.
Yes.
So it means the tumor is also involving the temporal lobe. And I'm sorry to bring you back. What do you mean by, okay, maybe anyone else can explain. They are talking about, in presenting issue of presenting complaint, they are talking about left homonymous hemianopsia. Then they're saying cranial nerve number 2 intact. Did you see that? If anyone saw also that.
Yes. In the workup, go back to the workup. You had a workup on cranial nerves.
Even here, summary.
Yeah.
See what they are saying?
Yeah, I see.
Cranial nerve demonstrate left homonymous hemianopsia. Then cranial nerve number 2 and 12 are intact. That's not right.
No, doctor, I think it's just English. I think this is just English. If you add otherwise here, that they are telling you that the left homonymous anopsia is the only abnormality seen. It's not like they're saying that it's intact. So this otherwise in front here changes everything on the sentence.
But which cranial nerve is affected when you get hemianopsia?
Cranial nerve 2.
I think the way they are presenting these cases, there's something wrong there, because even if you check in your exam, they are saying headaches reproducible by bending over or coughing. That's not on examination. That's maybe in a system review, and in system review in neurosurgery, it's part of issue of presenting complaint. I think there's something wrong the way they are presenting the cases.
Yeah, I'm sorry, it's poor internet. The difference here is really a difference in system, more detailed in the physical exam, whereas the Americans, which this case comes from an American textbook, is a little less emphasis on the physical exam and more emphasis on neuroimaging and management.
Okay. Okay. Can you go to the next image? Here, I wanted just to show people who were with us last week. We were discussing about the intra and the extra-axial tumor. Just check properly this image. That's an intra-axial tumor, comparing to the one we saw last week, which was extra-axial. People who were with us last week will understand that. Can you go back to your slide and show us that image? You will see that this is a purely intra-axial tumor.
So, Dr. Kabulo, you were talking about the difference between the intra-axial CT scans. I don't know if it's all right, or you have something to say before I continue.
Yes, you can now carry on. I was just showing people who were with us last week who were discussing about intra-axial and extra-axial.
Okay.
This is now an intra-axial tumor. Yeah.
Okay. Thank you very much, Dr. Kabulo. So with this, we'll have 3 differential diagnoses here, just with the imaging. The first one you have, which is most likely, which is a glioblastoma. Another possible differential diagnosis could have also been a metastasoma to the brain or even a brain abscess. For this presentation, the mock-up, other laboratory investigations will be requested, which include the routine labs, metastatic workup, which tests protein-specific antigen. So these other laboratory tests are just to rule out possibilities of primary CAs in the other systems of the body. Other imaging tools which could be requested could also be chest X-ray, mammography. In case if it was a woman, CT of the chest, abdomen, primary tumor in other places of the body, so as to rule out the secondary metastasis to the brain. Now, for the management of this case, those who are involved for this kind of management, you have the neuro oncologists, radiation oncologists. So I'll end there with the presentation. So now I'll go to the second part of this program, which is a literature on the glioblastoma.
Sorry, my friend, before you
follow
continue there,
this outline.
I want to make a comment. Okay, even this one or the previous one, yes, this one. You know, these images are showing a ring enhancing lesion, which is irregular in shape. There are multiple of them. You can see also brain edema around. But what is pointing more towards a glioblastoma, if you check the image C, you see the tumor is following the corpus callosum and crossing the midline. Usually, yes, you see that side, it is following the corpus callosum because the glioblastoma is following a white matter. And up to the other side, if you get a coronal view, you will see it has a butterfly appearance. That is the element showing us that this is a glioblastoma rather than abscess. But of course, abscess is one of the differential, because you can see on your left, there's a very big tumor and another one very small. That could be a daughter lesion, because abscess, usually you get a daughter lesion there. So yeah, that's the comment I wanted to make there. Thing which is telling us that this is a GBM instead of abscess. Thank you.
Okay, thank you very much, Dr. Kabulo. So we are going to follow the following outline: introduction, epidemiology, etiology, pathophysiology, clinical presentation, differential diagnosis, workup, treatment, and prognosis. The term glioma is usually used to describe primary tumors of the brain, and there are a variety of them. They include procystic tumors, of which falls on as a subtype. We also have oligodendrogliomas, mixed gliomas. So you can see that glioma simply talks about tumors of the supportive cells of the brain. Glioblastoma multiformis is the most common primary tumor, the central nervous system, and accounts for almost 80% of all the malignant tumors of the brain. So currently, there's a nomenclature for gliomas, which is that of the WHO classification, and which is grade 1 to grade 4. based on the level of malignancy. That is, you base them on their level of differentiation, and it is determined by histopathology after you do a biopsy of the lesion. So the gliomas are those that are a kind of well differentiated compared to the other fellows which range from grade 2 to grade 4. Whereas now the grade 2 to grade 4 gliomas are those who are highly malignant and invasive, and thus they are differentiated. So GBM, being most aggressive, invasive, and undifferentiated, falls under grade 4 according to the WHO classification. So histologically, you have cellular atypia, anaplasia, mitotic activity, microvascular activity, and necrosis. And I reiterate on the aspect of necrosis, which is a very typical feature of glioblastoma multiforme. A vast majority of these malignant tumors are supratentorial, meaning that they usually arise at the level of the cortex. Like for the case of this patient, which is the intraaxial tumor, you can see that the tumor was at the level of the white matter, of the brain, and they are highly infiltrative, following the white matter tracks, which Dr. Cablo just mentioned some few minutes ago. How the tumor, they follow the white matter track and reaching the corpus callosum. Epidemiology, global incidence less than 10 per 100,000 people. Survival rate ranges between 14 to 15 months following the diagnosis, and it accounts for 50% of all the gliomas in all age groups. There's a high incidence of gliomas in high-income countries compared to the less developed countries, but this could be due to the fact that maybe there's underreporting, or maybe article that is number of articles published on cases are not enough compared to that in the high-income countries. And blacks are less prone to GBM, and the incidence such as the Asian, the Latinos, and the whites. For the etiology, the etiology is usually idiopathic in most cases. There are also some genetic predispositions, like for example, patients who have neurofibromatosis, tuberous sclerosis, Lee-Fourmeny syndrome, like which is also present in the patients who have GBM. High dose ionizing radiation, which is a common risk factor for all, is the only confirmed like for GBM, even though sometimes in some studies found it to be controversial. Other factors incriminated, you can also have some environmental factors, cell phones, electromagnetic field, occupational risk factors. That is in the supratentorial region, but there are also occurs in the infratentorial region, notably at the level of the cerebellum, the brain, and also the spinal cord. So clinically, you can divide GBM into primary and secondary types, with the primary types of glioblastoma usually occurring in patients who are greater than 50 years of age, and they arise de novo without prior clinical or histological evidence of a precursor lesion. Whereas compared to the type, which usually occurs in patients who are less than 45 years of age, as a duration of pre-existing age or grade 2 or grade 2 the gliomas. As for the pathology, grossly, GBM, you have multifocal cystic areas. And a well-known feature of GBM is the variation of its gross appearance from one region to another, meaning that the size or maybe the location of this is not fixed. It varies from patient to patient. Some of the zones of tumors are firm, and you also have some regions which show cystic degeneration and hemorrhage. And the tumors is usually single, relatively large, irregularly shaped, arising in the white matter, as it was the case of the patient I presented, which was evidence on the imagings. For the genomics of glioblastoma, primary GBM usually occurs due to alterations in some genes, such as the epidermal growth factor receptor gene, whereby there's a problem with the gene amplification. We also have overexpression or deletion of B16 and the loss of heterozygosity chromosome on the long arm of chromosome 10. So the loss of heterozygosity chromosome is specific to and is common in both types of gliomas, of glioblastomas. The characteristic feature of GBMs include overexpression of PDGFA factor, and also more specifically, 53, which is common also in patients who have a leaf for many syndrome, as I said earlier. Now, methylguanine methyltransferase promoter methylation is associated with greater response to one of the chemotherapeutic agents, and thus it increases survival rates. As for the clinical presentation of tumors, the clinical history usually spans less than 3 months, unless you have secondary which can take place over years. And in rare cases, the symptoms occur abruptly, and this might be mistaken for a stroke. Like what you will see, that is what the signs and symptoms that you will see is based on the 3 mechanisms by which the patient will. This mechanism include by the tumor, the effects of raised intracranial pressure, and tumor locations, as it was the case of the patient that presented. So the common patient is a progressive neurological deficit, usually motor weakness, as was the case of the patient. You could also have headache, symptoms of raised intracranial pressure, which was the case of the patient. Another feature too is seizures, which can be simple, partial, complex, or generalized. But for the case I presented, the patient did not present with seizures. Also, the patient could also have alteration in the cognitive function. As for the patient I presented, the patient had problems with the memory. The focal signs, you could have sensory loss, aphasia, visual problems, hemiparesis, as it was the case of the patient. So the patient diagnosis. Now, for the workup, so the case I presented, the diagnosis there was space occupying lesion. So you see that the workup there will be kind of different for here, because at that stage, we do not have a fixed diagnosis. We don't have a fixed diagnosis. We had a lot of differentials, so that we included other workups so as to confirm to find out the most likely diagnosis. But in case you want, like for if you want to confirm the diagnosis of glioblastomas, no laboratory studies actually is indicated. The first step is usually an imaging technique, which could be invasive or not. Like for the invasive procedure, catheter angiography, so it's usually not necessary in diagnosis from some studies. Non-invasive techniques include the CT scan and MRI. So the gold standard imaging technique, which is used to diagnose MRI, which can be MRI with or without the gold standard imaging technique which can be used to diagnose a GBM will be an MRI with and without contrast. This is because of its superior soft tissue contrast. But in some cases whereby you can have an contraindication, like for example, a patient who has a pacemaker, you might turn to go back to CT scan first. Or maybe if you're in a setting like in a low and medium income country whereby MRI is expensive, so we might like to go first for a CT scan. From a CT scan now, maybe now we refer to a neurosurgery unit now. The health personnel they might want to request for further imaging. On CT scan, GBM usually appears as an irregularly shaped hypodense lesion with a peripheral ring-like zone of contrast enhancement and a penumbra of cerebral edema. So this is usually on the axial view, but as Dr. Kabulo said earlier in the presentation, in case you have for a coronal view, when there's all this spread of the tumor to the corpus callosum, you can have that butterfly appearance. So on MRI scans, you could have hypointense lesion on T1, whereas in case you have on T2 with MRI scans, you instead have a hyperintense lesion. So the usual finding on the MRI scan, which is enhanced with gadolinium, you have a central area of necrosis surrounded by white matter, or let's say vasogenic edema with a ring enhanced lesion. And this ring enhancement is due to the fact that there's a kind of absorption of the contrast by abnormal blood vessels at level where there are neoplastic cells. And the tumors are usually unifocal, but it can also be multifocal, like it was the case of the patient I presented today. So here is so here are some images from Farina and Ife al, which was adopted from 2003. So you could see various presentations of glioblastoma multiformes on MRI. Like for example, here you have on this imaging here you have the irregularly ring enhanced lesion with the perilesional edema and the necrotic center. Here, and you could see the mass effect plus or minus here, but here you could see the invasion here into the white matter. Whereas here you instead see a homogeneously enhancing mass at level of the frontal lobe here, and there's no associated edema. So this here a different presentation, like a different way of which the glioblastoma can present on MRI. But here at this level here you instead have an ill-defined infiltrative mass medial frontal lobe with no appreciable necrosis. But now, like for this imaging and this one for seeing. So now you have newer techniques like PET scan, MR spectroscopy, which are used in difficult cases because you consider the images C and D are not like kind of typical for glioblastoma. So, but these images can actually help us here sometimes in difficult cases to make a diagnosis. EEG, that is an electroencephalogram, might show epileptogenic spikes, but they are not specific. Also, lumbar puncture is usually contraindicated. Like for this patient, a patient who presents with signs of raised intracranial pressure, that is an absolute indication for a lumbar puncture. But the lumbar puncture sometimes too is useful in ruling out a lymphoma, as it was the case of this patient. One of the differential diagnoses was a CNS lymphoma because with an LP you could identify malignant cells in the CSF. As for the histologic feature, that is after brain biopsy, but the presence of necrosis is an essential feature that will help you, that guide you for the diagnosis of a glioblastoma. So as for the treatment, managing GBM remains the most tedious task in clinical oncology. And new surgical approaches, radiotherapy and adjuvant chemotherapy has shown an increased survival and quality of life for GBM patients, but the prognosis still remains a little bit low. So the current standard of care for high-grade gliomas, such as glioblastoma, include not only therapeutic management, but it also involves supportive care. Like for example, you have a patient that comes in an ER, maybe with the seizures, with a sense of raised intracranial pressure. So you will not just go and say, hey, guess what, let's go to surgery, let's go to radiotherapy, chemotherapy. The first thing that you will do, the common routine is to optimize the patient. By optimizing the patient, you actually alleviate the symptoms. So in this case, for the cerebral edema, which could cause the signs of raised intracranial pressure, you have agents for that. You also have to handle the seizures, possible GIT abnormalities and lesions. So for the symptomatic relief, you could have dexamethasone, which is kind of the preferred corticosteroid for this patient, so as to manage the raised intracranial pressure due to its low mineralocorticoid activity. Levetiracetam is a drug of seizures. That is, if a patient presents with seizures which are suspecting a GBM, so levetiracetam is a drug of choice due to its low toxicity profile and no interaction with available chemotherapeutic agents. Now, for the treatment proper, biopsy is usually indicated in some situations, like for example, you have a patient who has a poor medical condition, like a patient presented, let's say, with a ASA3, the extensive surgery might be difficult, or maybe due to the extent of the lesion, you might just want to do a biopsy so as to know what. So the location of the tumor too can prevent safe gross total resection, or maybe non-typical lesions on imaging. Like I presented before, whereby the the presentation was not typical. Surgery is the mainstay of standard care for GBM, and the extent of surgical resection depends upon the site and the eloquence of the brain area involved. Tumors which are multicentric, bilateral, and which are located in eloquent cortex, basal ganglia, are not good for surgical intervention. So usually for this kind of patients, most of the time you don't do a biopsy and you might manage with other treatment measures. So based on the fact that GBM is very invasive, it means that the cure cannot be attained only by surgery alone. So, and the occurs in most cases. So the goal of surgery is to maximize the extent of resection while at the same time minimizing the neurologic injury as much as possible. So that's why this type of tumors are very, very difficult to handle, because you might want the tumor, but at the same time, after the resection, the patient has little or no neurological injury as a result of the surgery. This usually assessed by the Karnofsky score. So usually patient with a survival rate, patient in with a Karnofsky score of less than 70. The case I presented, the patient was informed that that significant portions of the brain of the tumor could not be removed. So a stereotactic biopsy within the right frontal lobe was tumor genetic signature was established. So further surgery was not recommended for the patient. So due to the city of diet, so it was kind of difficult to operate. So the case I just presented. So now let's try a little bit to elaborate on the surgical technique in management of glioblastoma. So in cases where functional MRI what you simply do is that you want to help the patient, but at the same time you don't want the patient to suffer some, so that everything will be all right, like let's say for the language area, and to help you appreciate the brain so that you don't go and injure this. So MRI guidance, intra-op MRI mapping, and neuro monitoring, these are also used. So once you have the patient in front of you and you're about to do the anatomy, you go into the dura and you cross through an electrical tree, which is usually which is a bipolar device with a sharp cut. So the corticectomy will be done in such a way that you remove like the underlying tumor without damaging the normal section of the brain. So, and in this case, the bipolar electrical tree is a very good device. This is because tumors are well vascularized, and in this case, the best instrument that you need is actually a bipolar electrical tree together with suctioning, so as that you use to dissect the parenchyma, so as to avoid the maximum bleeding as possible. So so once you're in the cranial cavity, so macroscopically, that is what you're going to see macroscopically. Most of the time, a grayish pink fiber and a mass, which is usually hemorrhagic. So which is really hemorrhagic, and you can have surrounding edema around the lesion at the level of the white matter. So the infiltrative nature of GBM makes it lack a true margin in most cases. As on the imaging there, you could see that the ring lesions were kind of irregular, and in the other images, to delineate them was kind of so in case you have a tumor which is usually like kind of very extensive, so in case surgery actually is to be attempted, usually the surgeon will prefer to go in for a full or partial lobectomy. This is because you trying to go like and trying to remove only the tumor you can cause uncontrollable bleeding, since the tumor is fibrous and well vascularized. So patient selections before going for surgery, you have to do good patient selection. You should have a detailed knowledge of your anatomy, and you should be, and intra-op, you should be aware of any possible complication, because the slightest mistake, the life of the patient will be at stake. So the useful tools during the surgery, as we mentioned, no navigation, which include functional MRI, tractography. Just release this. So, okay. So now we'll go to the second mode of treatment, because I said to manage glioblastoma, usually surgery is not enough. So usually you have to, in most cases, you have to associate surgery, radiation therapy, and chemotherapy. So usually after doing the surgery, therapy follows, and this will destroy the remaining tumor cells and thus improving the life expectancy of the patient. So the radiation therapy of 60 gyro is a standard following biopsy or surgical resection. The involved field is generally defined by the area of the tumor plus a margin of 2 centimeters. Brachytherapy, stereostatic radiosurgery are also effective therapies in case of relapse. That is, so the brachytherapy and stereostatic radiosurgery are used only in case of relapse. That had the surgery before you manage it, but it still reoccurs. Whereas its efficiency for treating newly diagnosed GBM is limited. So for the radiation therapy, there are several complications. The most common one is radiation necrosis, and which will be a differential, as we mentioned earlier, in case a patient presents back with similar symptoms, like let's say the patient had a glioblastoma before, and the patient presents with the same symptoms. So you should not just think about a relapse. You should also think about a radiation necrosis patient. At the same time, the radiation necrosis will also cause permanent neuronal damage, or maybe even radioresistance. And the radiation therapy is usually given together with temozolomide chemotherapy. So now let's talk a bit about the last modality of treatment for glioblastoma multiformes. So the effectiveness of several agents have been tested, and currently the one that is used, that is the first, which is an alkylation agent. Others, you have camustin, but you will see that these chemotherapeutic agents, they are some of them, their use is limited based on the fact that cytotoxic, and also they have dreadful side. Some of them have resistance in the course of treatment. So which is an oral alkylating agent, is actually a standard of care for patients. That is the first line for patients with GBM. But methylguanine and methyltransferase, which is a DNA repair protein, like it kind of gives this chemotherapy, that is the temozolomide, a poor response. So for this, when given to temozolomide, the MGMT promoter methylation, that will help now increase the chances of the chemotherapeutic agent working in case you are managing a patient with common side effects of temozolomide. You have nausea, fatigue, headache, constipation, and myelosuppression. So other agents such as the monoclonal antibody Cizumab is often used for other agents like carboplatin are used as second line in patients who fail first line response. So of GBM, only modest advancement has been in the treatment for the past years. The current treatments have shown to prolong the quality of survival for the patient, and the survival correlates inversely with the age of the patient. So the patient diagnoses a patient. Let's say the patient is not managed. The patient was supposed to be probably maybe due to constraints, due to ignorance, or maybe due to loss of follow-up. The patient will usually die within 3 months due to the aggressiveness of the tumor. Who receive optimal treatment usually survive between 1 to 5 years. So usually patients, so usually in 50% of cases, usually the patient will survive for 1 year. That is in 50% of cases. In 25% of cases, the patient will survive for about 2 years, and in about 10% or fewer cases, the patient can survive for 5 years after optimal treatment was have been done. So the variability in the survival rate between the primary and secondary GBM is controversial. So these are my references. So for the case that I presented, so the case was taken from 100 case reviews in neurosurgery by Raoul Janzial et al. And you can also have this article and the Medscape, which I used to like bring out the literature for the presentation.
Thank you very much, Benjo. It was actually an awesome presentation. Yeah, thank you very much. And Dr. Orik, over to you, sir.
Well, thanks. I think the first thing before I give any comments is, since Dr. Kabulo is here, if there's anything Dr. Kabulo would like to add, and if you have questions, please feel free. Do not feel intimidated. Ask questions. We want this to be really interactive. Dr. Kabulo, anything you'd like to add?
Okay, thank you so much for the great presentation. I think it was very, very good. And he mentioned almost everything. So I won't give my comment on like treatment to go deep on that, because we have also medical students here. Maybe the only thing I want to add or to explain is the use of dexamethasone on that case. That's the only brain edema where we use dexamethasone, because the other types of edema are like cytotoxic edema, the one you get in ischemic stroke, and you get also in traumatic brain injury. What is happening there? There is disruption of sodium-potassium pump, then sodium goes inside, potassium outside, then water follows the sodium. You get, that's a cellular edema. There you don't use dexamethasone. In interstitial edema, you get like when you have obstructive hydrocephalus with transependymal infiltration, the CSF is leaving the ventricular system to go into the brain parenchyma. That's one also, there's no use of dexamethasone there. The only type of brain edema we use dexamethasone, it's the vasogenic edema, like he mentioned, because that edema is coming from many things. One, the tumor which is growing, it's a cellular tumor. It needs to be fed. Those cells need to be fed. It means you have neovascularization. You get new vessels which are going now to those cells. And those vessels are abnormal cells. They leak. Then when they are leaking, you get edema, which is peri-lesional edema. And the other thing, that tumor can also compress the existing vasculature, causing stasis and extravasation. Then you get also that edema. But steroid, when you are giving, they stabilize those small vessels and they prevent the leak. So yeah, otherwise, other things were perfect. I really like the way he presented. Thank you so much.
Thank you to Dr. Kabulo. Thank you very much for the additional knowledge.
Thank you, Dr. Kabulo, for the comments. Thank you so much. Yeah, if there is any other question, please you can unmute and ask your question before Dr. Orik give his final comment. In the absence of any question, yeah.
Yeah.
Okay.
Berjo, can you stop sharing your screen, please? I like to think that when there's no question, there's two things. Either everybody understood everything, which is highly unlikely, or nobody understood anything. I think we might head to, let me turn on my camera here. I think we might head to calling people out in the next sessions, because I'm actually surprised how timid people are. This is not a show of of knowledge. It's not about displaying knowledge, it's about learning. And learning starts with having the courage of humility to ask questions. Feel free to ask questions, you know. I know for some people, especially those who are new, some of the things we say here might sound high level or inaccessible. Do not feel bad, because some people here have had a leg up, you know. Some people have been with the group for more than a year. So they've gone through neuroanatomy lectures for the brain, for the spine. They've gone through basic neuroradiology lectures. And so that makes sense that they understand certain things that you might have a hard time with right now. So please, please, please feel free to ask questions. But otherwise, I think we really need to explore the pointing out people and asking questions. In the US, they call that hazing. For some people, they call it pimping. We don't want to pimp people, you know. We want people to come up and ask questions. Yeah. So one last call again before we start pointing out and asking questions. Does anyone have a question? Okay. So no one has a question.
Like
That's
I
perfect.
saw
Well,
Stefan raised his hand.
Oh, okay. Stefan Dumbe, sorry, I didn't see that. Yes, go ahead, Stefan.
Okay, thank you for your presentation. Well, my name is Stefan Dumbe. I come from Bala, to medical student. So I have difficult about this subject because I'm francophone. But one question. Okay, when you say that it's not good to use dexamethasone for the patient who have glioblastoma, what should I use to resolve the edema for this patient?
Good. Thanks for asking. I think perhaps you didn't understand what Dr. Kabulo said. So what Dr. Kabulo said was this, that this is one of the very few cases when you have to use dexamethasone, because he went on to say there are different types of edemas, brain edemas. He spoke about cytotoxic, he spoke about the interstitial, and when he went ahead and even defined the pathophysiology, right? When he said cytotoxic, he spoke about the situation with like ischemia. You know, if you have ischemia, because what you need to go back to your basic physiology. Dexamethasone is a glucocorticoid, right? As a glucocorticoid, it gets transported by transcortin. Because it's lipid soluble, it crosses the barrier and goes at the level of the nucleus, at the level of the rank receptor, to act on NF-kappa B. When it acts on NF-kappa B, what does it do? It has anti-inflammatory effects. And if you think about the inflammatory effects that you have normally, you think about things like vasodilation, you think about the recruitment of inflammatory cells. So for you to use dexamethasone, for you to use dexamethasone, you need to have a process that looks like that inflammatory process for it to act. And if you're thinking about cytotoxicity, for example, you don't have blood going to a particular section of your brain. If that blood doesn't go there, then you don't get oxygen, you don't get glucose. If you don't get oxygen, then you move from aerobic to anaerobic respiration. And if you're in anaerobic respiration, you produce less ATP. If you don't have ATP, one of the things that suffers are your pumps. Among the pumps, you have the sodium-potassium pump, very important. What does it do? It keeps sodium outside of the cell and potassium inside of the cell. So no ATP, sodium starts coming inside the cell, potassium starts going outside of the cell. As sodium comes, sodium often travels with water, right? So if sodium travels with water inside the cell, you have edema. So that type of edema is called cytotoxic edema. in all we explained there, we didn't speak about inflammation or anything related with inflammation. So it would make sense that in such a situation, you shouldn't use or prescribe glucocorticoids. And then Dr. Kabulo explained about interstitial edema. He gave the very good and very common example of hydrocephalus, obstructive hydrocephalus. If you have obstructive hydrocephalus, the hydrostatic pressure within the ventricular system increases. And since it increases, again, you go back to basic physiology, right? If it increases, what happens is water gets pushed out of the ventricular system and into the parenchyma. So what happens there is what we call transepidermal resorption or reaction. So that water that goes into that interstitial fluid, interstitial space, you cannot resolve it with glucocorticoids. Now, if you think about glioblastoma multiforme as a malignant tumor, there is an inflammatory process that happens, right, due to the modification and aggression of the surrounding environment. And that's one of the things that explains that important peri-lesional edema that we notice. And in that case, like Dr. Kabulo said, it is one of the few cases in which you can prescribe that. I hope I did justice to what you said, Dr. Kabulo.
Yes, thank you so much, Dr. Ilrik. That's perfect. It was even detailed. So yeah, that's it, Stefan. It's only the only type of edema where we use dexamethasone or steroid. Thank you so much.
Okay, thanks.
And thank you for being the first to come up with a question. Does anyone else have a question? Because that's what we want to do here. We want to answer your questions. We want to make sure you understand. We're not trying to intimidate anybody. Okay, so please ask questions. Don't think anything is too small or don't think any question is stupid. It isn't. Ask your question. Okay, nobody asking questions?
I have a question.
Yes.
So my name is Umutoni Alice from Rwanda. So like on the case presentation that Berjo did, it seems that we can exactly know the location of the tumor. So my question is, can a glioblastoma arise in different parts of the brain? And will the symptoms be like different, that to confirm it, we have to use a CT scan to see it? Or like there is clinical presentation? Because like I'm working on a DH right now in my rotation. When someone presents with a headache and other symptoms, like can we have like the first symptoms for a glioblastoma or any kind of it's not really for the meningioma, it was like kind of specific, but for this one I don't think it is really specific. Like, can we have like clinical presentation to make it different from other primary tumors?
Thank you very much. I see Dr. Kabulo is unmuted, so I'll let him speak first.
Okay, you can start. You can start, Ilrik, if you have something to say.
Oh, no, I wouldn't dare. Please go ahead.
Okay. Thank you so much. Thank you, Alice. You want to know if there's a specific presentation on glioblastoma. It depends on the location of the tumor. And glioblastoma usually is located in the supratentorial. It's very rare to get glioblastoma in the posterior fossa. Very rare. Unless you get like what they say, drop metastasis from supratentorial to posterior fossa. Then you get glioblastoma there, but it's very rare. You get the glioblastoma in supratentorial. And the presentation, there's no specific presentation for glioblastoma. Many of those space occupying lesions, they don't have like a specific presentation. You only think about the duration of the symptoms, and you get signs of raised ICP which are there for a long time. Then you think which one is the slow growing tumor. If it's fast, then you think, but there's no specific sign for a specific tumor. No, it depends on the location of the tumor. I don't know if you get that.
Yeah, Alice, did you get the explanation? Oh yeah, great. Thank you. Thanks for responding.
Okay. She said yes.
Yeah. And thank you again, Alice. These are the kind of questions we're looking forward to, because your questions let us know what we want, what we need to explain. We might think you understand something, and we don't say it, whereas we're supposed to explain. Or maybe we say something we think you do not understand, but you already understand. So that we don't waste your time, it's good that you ask these questions. So we welcome them. Please keep them coming. Keep them coming, really. Anybody else has something they want to ask about this case? Okay, I guess we can take that as at least as a win. We had 2 people come up today. We hope that the others will feel comfortable enough to ask questions the next time. The important thing that we're seeing here, I really love these courses, that the way we're seeing them, because we move from the clinical concept, we have the evaluation. So if you get evaluated in the future, you should be able to answer these questions. You have the neuroradiology. We look at the management as well. So it's a complete pipeline of from start to finish. And you should enjoy this. If you have more questions, or if you're more interested in some of these things, please go online, look at articles, even in the WhatsApp group, ask questions, go on Radiopedia. There are a lot of really good, detailed neuroimaging. If you type, I don't know, glioblastoma multiforme, you find so many things. You even find videos. And that's a great way to learn, Don't wait for something to happen. Start learning now, so that you can be one of the better candidates, the better residents, or the better neurosurgeons.
Okay, Dr. Ilrich, since they are not asking, let me ask. Why is it difficult to do a total resection of this kind of tumor? That's an easy question. Yes, wow, praise.
I think it's because such tumors they are highly vascularized. So if you do a total resection, they may be heavy bleeding.
No. That's not the reason. Dollen can go into the cavernous sinus. It bleeds there, but can remove a meningioma from cavernous sinus. You see? Try to think again.
It looks like Ben Gathwa is ready to answer the question. Ben unmuted there. Go ahead, Ben.
I think it's because when you're operating on a glioblastoma, the margins are not clear. It's not very easy to differentiate tumorous brain from normal brain.
Yeah, then use a specific words.
Surgical margins are not clear.
Why is the margin not clear?
Well, it's an interaxial tumor, and it's not delineated from the pathological. The pathological brain is not delineated clearly from normal brain tissue.
You might get another tumor where you get the demarcation between the tumor and brain, which is not clear, but you still do a total resection. You are close, but I want you to pronounce one word only.
It looks like Tunde is up for the challenge. Yes, Tunde, go ahead.
Okay, I actually think it's because of the aggressiveness of the tumor. So it tends to spread into the brain. So it's really hard to get the demarcation, so because of the aggressiveness.
Okay, Ben.
I love this.
Mm-hmm. Ben, you want to say something? I saw you raised your hand.
Oh, sorry, let me think again. Let me rethink it.
Tunde, your hand is still up. What do you think? Okay, it went down. Yeah, this tumor is an infiltrative tumor. It infiltrates the brain. when you want to do it, there are types of tumors. When the tumor is growing, it is pushing the brain parenchyma. It is pushing structures. You see, like you are standing up, someone who's coming in between you and pushing you away from him. But this tumor, it's like sending ramification. It's like infiltrating the brain, which is very difficult. That's why you are saying it's not demarcated. You won't see properly the what? The interface between the tumor and the brain parenchyma, because it is infiltrating that, which makes difficult to do a total resection. That's why people, they just go either for biopsy, you do a biopsy, then you do your radiotherapy and chemotherapy, or you go and do partial resection, then you continue with radiotherapy and chemotherapy. Thank you.
Yeah. So fantastic, and I think if anyone here is interested in neuro-oncology, they'll find that there's a lot of amazing research and future out there for something like glioblastoma. The reality is that we have not been able to push the needle that much in the past 30 years. There has been one event, obviously the Stoop protocol, which is what Berjo presented with temozolomide and radiotherapy concomitantly, associated obviously with surgery, which sort of increased overall survival, but just a little bit, not that much. And it gets back to what Dr. Kabulo said, like what he mentioned, right? He made it so simple, so basic, and that's how you know when you understand a concept. When you really understand a concept, you can make it so facile that anybody understands it. There is so much research around how this tumor infiltrates. So like recently, that's about 5 years ago, people found that actually when you see a lesion on the MRI or the CT scan, which is a glioblastoma lesion, they were able to detect glioblastoma cells on the other side of the hemisphere. So say you have it on the right hemisphere and you have a really small lesion, maybe 2 centimeters, and you're thinking, oh my goodness, this is just 2 centimeters. We'll go in there, we'll cut it out and then go away with it. What they found is that the cells are already even outside of the mass that you can see with the MRI. They're already outside of the mass that you can see with the naked eye. They're already on the other side. And if you think about that, what that means is then what is the role of surgery and what is the role of radiotherapy and what's the role of chemotherapy? If you think about this just as a surgical disease, then what you try to do is get everything out, right? Now, let's think about it. If you're going to get every single glioblastoma cell out, then you need to be able, like Dr. Kabulo said, to find the limit and then take it out. So some neurosurgeons proposed, first of all, maximal resection. Some propose supramaximal resection to give more margins around it. And then when the information came that some of this, the cells can be on the other side of the hemisphere, then you ask yourself, wow, if the lesion is at in the right frontal lobe, will I go and take the right frontal lobe and the left frontal lobe of the person? And if you do that, what does the person stay with? Even say you save the person from the disease, what about the morbidity? And that's why in neuro-oncology and glioma surgery today, people always balance. It's not just about like, oh, I resected everything, I'm a fantastic neurosurgeon. No, you need to ask yourself the question, how did my patient come and see in terms of functional outcomes, in terms of morbidity, and in terms of Karnofsky performance scale? And after I did my surgery, what is my patient like? So if your patient came and was had good language, had good, no cognitive behavior, behavioral problems, and after your surgery, the patient doesn't recognize anybody in their family, you need to ask yourself what was the benefit of that surgery? And that's that higher level of understanding neuro-oncology and glioma surgery. I invite each and every one of you to go and read more about that in glioma surgery. It's really, it's fantastic. And if you can check the publications of Michael Sogru, who's an American neurosurgeon now in Australia, he equally speaks about connectomics and the fact that when you're resecting all these lesions, especially white matters, there's some white matter connections between gray matter that are very important. So you can't just go out there and just be cutting everything out because you say that's where the tumor is. You have to be careful. That was a fantastic question. That's lovely.
Okay, I think let me give my last comment before I leave. Thank you everyone for coming. This was a nice session. Feel free, like Dr. Ilrig is saying, every day when you are joining, feel free to talk. No one will intimidate you. And we are there to learn. We are learning from each other. Ask your questions. There is no stupid question, like he said. Glioblastoma, that's the commonest primary brain tumor. You find it the moment you be a neurosurgeon, you will see that more patients will come with brain tumor, you get more glioblastoma. And glioblastoma, it's an astrocytoma. And astrocytoma, it's coming from astrocyte, it's coming from glial cells. That's why they call them gliomas. So it's an astrocytoma, but grade 4 according to the WHO classification. Remember, there is the grade 1, pielocystic astrocytoma, grade 2, diffuse astrocytoma, grade 3, anaplastic astrocytoma, and grade 4, that's glioblastoma. There is also another variant, gliosarcoma. So the glioblastoma can be primary or it can be secondary. Primary glioblastoma is the commonest. Secondary is coming from transformation of the diffuse astrocytoma. From grade 2 to grade 4, you get that glioblastoma. And remember, long back, I presented, I think on AFAN, I presented on WHO 2016 classification of brain tumors, where we mentioned that according to the new classification, there is now what we call glioblastoma IDH mutant and glioblastoma IDH wild type. And the other one, which is called the non-otherwise specified. So it's also good to know that, because that's the molecular classification of glioblastoma. It's also affect the outcome. That's what they are doing now elsewhere. Of course, like Professor Isabel Germando, I like usually when she's presenting on glioblastoma, she does also molecular testing. So that's it. It's a very, very aggressive tumor, like we said, which the overall survivor is not good. When you get it, the moment of diagnosis, usually they say at 3 months, you lose the patient. But there are cases where you can go over that. So treatment, of course, it's surgery, but combined to radiotherapy and chemotherapy. Surgery is just to decompress or to name the tumor. In neurosurgery, there are types of brain tumor where you can go. There are type of surgery where you are just going for you to name the tumor, or you can go to decompress, not to remove the whole tumor. So yeah, that was my last comment because I wanted to leave you guys. Thank you so much. We'll meet next week with this Neuro Oncology. I will make an effort to be there every Saturday when we are talking about Neuro Oncology. Thank you.
Fantastic. I think we can all call it a weekend, right? Thank you so much for coming and have a great weekend. See you next week.